program is for educational purposes only and reflects independent editorial commentary. It is not medical advice and should not replace clinical judgment or review of primary sources and guidelines. The views expressed are those of the host and contributors.
Welcome back to EP Edge Journal Watch. This is Dr. Sharma, and I'm glad you are here for issue 25, June 2026. First, thank you for the suggestions and questions. They help make this series more practical for the EP lab, clinic, consult room, and journal club. I am also very excited about the EP Edge Journal Watch podcast with the Heart Rhythm Society. These papers deserve a deeper audio conversation because they change how we consent, monitor, prescribe, and choose devices. The theme this month is Beyond the Binary. Stroke risk is not simply male versus female. Ablation success is not recurrence versus no recurrence. PFA is not simply safe versus unsafe. ICD benefit is not only ejection fraction below 35%, and device selection is not just lead versus no lead. We will cover stroke prevention, AF risk scoring, AF ablation endpoints, PFA workflow and biology, device strategy, battery longevity, competing defibrillator risk, and one EP lab pearl where the VA interval can absolutely fool you. We start with the option bleeding risk substudy, with the editorial by Schiavone and DiBiase. The question was practical. After AF ablation, can left atrial appendage closure preserve stroke protection while reducing long-term bleeding compared with oral anticoagulation? Option randomized 1600 post-ablation AF patients with elevated stroke risk, 803 to left atrial appendage closure with Watchman flex, and 797 to anticoagulation. This substudy stratified patients by HAS-BLED score 0, 1, 2, and 3 or higher. The primary effectiveness endpoint was death, stroke, or systemic embolism at 36 months. That was similar between arms across HAS-BLED categories. The interaction p-value was 0.73, meaning there was no evidence that the effectiveness of left atrial appendage closure differed by bleeding risk subgroup. The bleeding endpoint is the headline. In HAS-BLED 0, bleeding was 17.2% with anticoagulation versus 4.4% with left atrial appendage closure, hazard ratio 0.25. In HAS-BLED 1, it was 17.2 versus 7.5%, hazard ratio 0.41. A hazard ratio compares event rates over time. 0.41 means about a 59% lower relative hazard, but the absolute difference matters too. About 10 fewer bleeding events per 100 patients over 3 years in HAS-BLED 1. EP Edge, take low HAS-BLED, does not mean no bleeding risk. Option moves atrial appendage closure from only when anticoagulation is impossible toward a legitimate long-term strategy discussion in selected post-ablation patients. Next, female sex in AF stroke risk. McGarvey and colleagues asked whether female sex is a uniform independent risk factor or more of a risk modifier that matters mainly when age and comorbidity are present. Using TriNetX, they identified 942,642 patients with non-valvular AF from 2015 to 2025. They stratified patients by sex and age, under 65, 65 to 74, and 75 or older. They then used CHADS-WA, which removed sex from the score and performed one-to-one propensity matching. The outcome was cerebral infarction or arterial embolism over 1 year. In younger patients, female sex did not consistently increase risk. The signal appeared mainly in patients 75 or older. In older patients without additional risk factors and not anticoagulated, the hazard ratio was 1.244. That means about a 24% higher relative hazard, but the absolute rates were 0.783% versus 0.624%. or roughly 1 extra stroke per 629 patients over 1 year. With one additional risk factor, the older female signal persisted, but the hazard ratio was only 1.065, and the absolute difference was about 1 extra stroke per 952 patients per year. EP Edge take. Female sex should sharpen risk assessment in older comorbid patients, especially 75 and above. It should not automatically drive anticoagulation in otherwise low-risk younger women. Now to early recurrence after PFA versus radiofrequency ablation. Villarreal and colleagues studied whether symptomatic early recurrence during the blanking period differs between PFA and RF, and whether early recurrence still predicts late recurrence. This was a prospective registry from Beth Israel Deaconess. After propensity matching, 962 first-time PVI patients were analyzed, 420 RF and 542 PFA. Early recurrence, or ERAT, was AF, flutter, or atrial tachycardia lasting more than 30 seconds within 90 days. Late recurrence was assessed after that through 9 months. PFA had less early recurrence. 3-month freedom from atrial arrhythmia was 86.6% with PFA versus 73.8% with RF. The largest gap was in month 1, recurrence 9.8% with PFA versus 19.5% with RF. After adjustment, PFA had a hazard ratio of 0.61 for early recurrence, meaning about a 39% lower relative hazard. But once early recurrence occurred, it strongly predicted late recurrence, hazard ratio 3.78 for first month early recurrence and 4.10 for months 2 or 3. EP-EDGE take. PFA may reduce early inflammatory noise, but early recurrence after PFA is not meaningless. It should prompt closer monitoring, phenotype definition, and rhythm optimization. The next paper may change how we talk about ablation success, burden-based outcomes after AF ablation. Almerad and colleagues studied 165 patients with paroxysmal or persistent AF undergoing first-time ablation after implantable loop recorder placement. Median follow-up was about 41 months. Antiarrhythmic drugs were stopped at 3 months, and quality of life was tracked. The key metric was atrial tachyarrhythmia burden, the percent of monitored time spent in AF or atrial tachycardia. Across the cohort, median burden fell from 15% before ablation to 0% after ablation. In the 76 patients who had recurrence, the result was even more provocative. Burden fell from 93% to 0.45%. More than 90% of recurrent patients achieved at least a 75% burden reduction. At 4 years, freedom from any 2-minute episode was 54%, but freedom from a 24-hour episode was 79%. Statistics translation. Kaplan-Meier recurrence asks, when did the first episode happen? Burden asks, how much arrhythmia remains? A patient can fail a 30-second endpoint but have an enormous therapeutic response. EP-EDGE take. Stop equating any recurrence with failure. Follow-up should include baseline burden, residual burden, symptoms, phenotype, and durability of benefit. Next, the time course of recurrence in paroxysmal AF ablation trials. Aguilar and colleagues asked whether the traditional 12-month follow-up endpoint is necessary for every paroxysmal AF ablation trial. They pooled 42 randomized trials with 10,246 patients and reconstructed recurrence timing from published Kaplan-Meier curves. Arrhythmia-free survival was 90.4% at 4 months, 83.4% at 6 months, 77.2% at 9 months, and 72.8% at 12 months. The important finding, recurrences were front-loaded. 35.9% of all 12-month recurrences had occurred by month 4, 61.5% by month 6, 85.2% by month 9. 6-month survival predicted 12-month survival with a mean absolute error of 4.2%, meaning the prediction was off by about 4 percentage points on average. Statistics translation. This was reconstructed trial-level data, not individual continuous monitoring. It is useful for trial design, not for saying an individual patient needs no long-term follow-up. EP-EDGE take. Trial follow-up may be shortened in selected paroxysmal AF studies, but clinical monitoring should still match the purpose: symptoms, burden, stroke risk, heart failure, or progression. Now, left atrial size in persistent AF. Does size matter? This Kaplan substudy asked whether left atrial volume index predicts ablation failure or whether it predicts recurrence burden and phenotype. Kaplan randomized persistent AF patients to PVI alone versus PVI plus posterior wall isolation. This substudy included 281 patients with baseline left atrial volume index and 12-month follow-up. Monitoring included implanted devices, loop recorders, twice-daily mobile ECGs, or Holters. Recurrence occurred in 46.3% at 1 year and 61.6% at 3 years. But left atrial volume index did not independently predict binary recurrence. The odds ratio was 1.01 per milliliter per square meter, with p equals 0.55. But among patients who recurred, larger left atrial volume index was associated with more burden and persistent rather than paroxysmal recurrence. The odds ratio for persistent recurrence was 1.78 per 10 milliliters per square meter. Statistics translation odds ratio 1.01 means left atrial volume index did not meaningfully change the odds of any recurrence, but 1.78 per 10 unit increase means larger atria strongly shifted the recurrence phenotype toward persistent AF. EP edge take. A large left atrium should not automatically mean do not ablate. It should mean counsel differently. Expect higher burden and more persistent recurrence if recurrence happens. Now to PFA biology, thromboinflammation and hemolysis after pentaspline PFA. Popa and colleagues studied 60 patients with paroxysmal AF undergoing first-time PVI, 30 with pentaspline PFA, and 30 with radiofrequency ablation. They measured inflammation, platelet activation, endothelial injury, hemolysis, nitric oxide, and renal function at 3 time points. The rationale is important. PFA is tissue selective, but electroporation can still affect red blood cells. That can release free hemoglobin, deplete nitric oxide, and potentially interact with renal function, inflammation, and thrombosis. Intravascular hemolysis occurred in 100% of PFA patients after an average of 42.8 deliveries. Nitric oxide decreased significantly in the PFA group only, by about 26.5%. No acute kidney injury occurred, which is reassuring, but hemolysis burden correlated with creatinine increase, inflammation, platelet activation, and endothelial injury. Female sex was the only independent predictor of significant hemolysis. Odds ratio 7.8. Statistics translation, odds ratio 7.8 means nearly 8-fold higher odds in this cohort, but the confidence interval was wide, so the signal is important but imprecise. EP edge take. PFA is not biologically silent. Use it efficiently. Optimize contact, avoid redundant applications, and think carefully in patients with renal dysfunction, anemia, or high anticipated lesion burden. The companion PFA paper is about workflow and durability. Rodriguez, Munoz, and colleagues asked whether pulmonary vein reconnection after pentaspline PFA is mostly a waveform problem or a technique problem. This was a single-center prospective study of first-time pentaspline PFA, PVI, with planned invasive remapping at least 30 days after, regardless of symptoms. 118 patients were enrolled, 94 underwent remapping across 3 workflow phases. Phase 1 used systematic orthognomofluoroscopy, reference images, stability checks, and repeat ablations if the catheter removed. Phase 2 added carina coverage and improved inferior vein mechanics. Phase 3 added left carina applications plus electroanatomical mapping and impedance-guided assessment of spline distribution. Per vein durability improved from 89.8% to 92.9% to 99.2%. Per patient durability improved from 60% to 76.5% to 96.7%. Statistic translation, per vein and per patient durability are very different. A few reconnected veins can translate into many patients with at least one reconnection. EP edge take. PFA durability is workflow dependent, but because more applications may increase hemolysis exposure, the answer is not simply more pulses. It's better pulses, better contact, orientation, carina coverage, and avoiding redundancy. Let's move to devices, starting with subcutaneous ICD or SICD in patients with prior monomorphic VT. The classic concern is lack of ATP. Monomorphic VT is often pace terminable, so choosing a subcutaneous ICD in someone with prior VT has been controversial. Botto and colleagues analyzed the Rhythm Detect registry across 37 Italian centers. Among 2,164 de novo SICD implants, 210 patients had prior sustained monomorphic VT. Median follow-up was 43 months. Recurrence sustained monomorphic VT occurred in 21 patients, or 10%, with 66 total episodes. All ventricular arrhythmias were successfully terminated by shocks. First shock efficacy was 93% for both monomorphic VT and polymorphic VT or VF. Final success was 100%. The annualized MVT rate was 2.8% per year. Appropriate shocks were 4.9% per year, inappropriate shocks 2.8% per year, and complications 2.3% per year. About half of patients with recurrent MVT underwent ablation, and no patient required conversion to a transvenous ICD for ATP. Statistics translation: annualized rates average events over time, but risk is concentrated in a subset. Selection bias also matters because clinicians probably avoided SICD in patients expected to need frequent ATP. EP edge take: prior monomorphic VT is not an automatic SICD exclusion. The key is whether frequent stable ATP responsive VT is likely. Next is CRT-DX versus conventional CRT-D. The question is elegant. In CRT candidates without sinus node dysfunction, do we really need an atrial lead, or do we simply need atrial sensing? CRT next trial randomized 636 patients at 23 Italian sites to 2-lead CRT-DX or conventional 3-lead CRT-D. CRT-DX senses the atrium using a floating atrial dipole on the right ventricular lead, but does not pace the atrium. The primary endpoint was a 1-year composite of all-cause mortality, cardiovascular hospitalization, and lead-related complications. The endpoint occurred in 13.1% with CRT-DX versus 15.6% with CRT-D. The hazard ratio was 0.82, and non-inferiority was met in both per protocol and intention to treat analyses. Atrial lead or atrial functionality complications were lower with CRT-DX, 1.3% versus 4.2%. Procedure time was shorter, 92 versus 107 minutes. Reverse remodeling was similar, and only one CRT-DX patient later required a standard atrial lead. Statistics translation: non-inferiority means CRT-DX was not unacceptably worse than CRT-D within a pre-specified margin. It does not automatically prove superiority. The clinical win is similar outcomes with less atrial lead burden. EP edge take: do not implant an atrial lead by habit. Ask whether the patient needs atrial pacing or only reliable atrial sensing. Now the ICD battery longevity paper. This one matters for patients, systems, and cost. Freeman and colleagues used the Pacemate National Remote Monitoring Dataset, analyzing ICDs implanted from 2003 to 2023. Over 15,000 single-chamber ICDs, over 10,000 dual-chamber ICDs, and over 17,000 biventricular ICDs. They compared time to replacement interval across Biotronic, Boston Scientific, Medtronic, and Abbott. Replacement interval is the battery point where generator replacement planning begins. First, every additional lead cost about 2 to 3 years of battery longevity. Second, manufacturer mattered. Among devices reaching replacement interval, Boston Scientific transvenous ICDs had the longest observed longevity across single-chamber, dual-chamber, and biventricular systems. Single-chamber median longevity was 151.3 months for Boston Scientific, 129.5 for Abbott, 107.4 for Medtronic, and 84.0 for Biotronic. Dual-chamber longevity was 134.1 months for Boston Scientific, 108.6 for Abbott, 92.9 for Biotronic, and 91.7 for Medtronic. Biventricular longevity was 110.6 months for Boston Scientific, 83.1 for Abbott, 78.2 for Medtronic, and 76.0 for Biotronic. Statistics translation: Kaplan-Meier curves handled devices that had not yet reached replacement interval. Cox regression identified manufacturer, program pulse width, and programmed output as major drivers of longevity. EP-Edge take: battery longevity should enter device selection. Fewer unnecessary leads, careful programming, and manufacturer differences may reduce lifetime generator changes, complications, and potentially cost. Next, competing risk in primary prevention ICD patients with advanced heart failure. Barshachet and colleagues pooled 5,168 primary prevention ICD recipients from 5 trials: MADE-IT-2, MADE-IT-CRT, MADE-IT-RIT, MADE-IT-RISK, and RAID. Patients were grouped by ejection fraction 20% or lower, 21 to 29%, and 30 to 35%. The primary endpoint was sustained VT or VF. The key statistical method was fine and gray competing risk analysis because death from pump failure or non-arrhythmic causes can prevent observation of later VT or VF. At 3 years, sustained VT or VF occurred in 28% of patients with ejection fraction 20% or lower, 23% with 21 to 29%, and 20% with 30 to 35%. Appropriate ICD shocks were 17, 12, and 11%. But mortality also increased 16%, 10%, and 9% across those same groups. Statistics translation: a subdistribution hazard ratio accounts for competing events. LV ejection fraction 20% or lower carried higher cumulative arrhythmic risk, but also substantially higher all-cause mortality. The editorial frames it well. These patients have more shockable arrhythmia and more non-shockable death. Both are true. EP-Edge take: ICD consent should say both things clearly. You are at higher risk of a rhythm the ICD can treat, and also at higher risk of dying from mechanisms it cannot treat. Our final paper is the EP Lab Pearl, the nearly zero VA interval trap. This vignette shows how slow atrioventricular nodal tachycardia, or AVNRT with a prolonged lower common pathway, can mimic typical slow-fast AVNRT. The apparent VA interval may be less than 70 milliseconds or nearly zero. In the first case, an 81-year-old woman had tachycardia cycle length 424 milliseconds, AH interval 356 milliseconds, and HA interval 68 milliseconds. That pattern could easily be called typical AVNRT. But ventricular overdrive pacing changed the diagnosis. The post-pacing interval was 570 milliseconds, and the tachycardia cycle length was 418 milliseconds. So PPI minus TCL was 152 milliseconds. A value greater than 115 milliseconds argues against AVRT and supports AVNRT. After right inferior extension ablation, tachycardia persisted. Repeat PPI minus TCL was 182 milliseconds. Left atrial mapping then found earliest retrograde activation at the left inferior extension, and ablation there terminated tachycardia. EP methods translation: in AVRT, the ventricle is part of the circuit, so PPI minus TCL is shorter. In AVNRT, the ventricle is outside the critical circuit, so it is longer. EP-Edge take: if a near zero VA tachycardia behaves like AVNRT but will not die with right inferior extension lesions, map the retrograde limb. The VA interval can lie. Let's close with the rapid recap. This issue showed us that left atrial appendage closure after ablation may reduce cumulative bleeding exposure. Female sex behaves more like a risk modifier than a universal stroke risk point. PFA reduces early recurrence, but early recurrence still matters. AF burden may be more meaningful than first recurrence, and left atrial size predicts recurrence phenotype more than binary success. We also saw that PFA durability is workflow dependent. PFA hemolysis is real. SICD may be reasonable in selected prior monomorphic VT patients. CRT-DX can reduce atrial lead burden. ICD battery longevity differs by manufacturer and programming. Very low ejection fraction creates both arrhythmic and competing mortality risk, and a near zero VA interval can fool you. All references and graphics are available on the LinkedIn newsletter, EP Edge Journal Watch, as well as on Substack at epedge.substack.com. Questions, suggestions, or concerns can be sent to epedge.cast@gmail.com. Thank you again for listening to EP Edge Journal Watch. I appreciate your time, your feedback, and your commitment to thoughtful electrophysiology. Take care, and I will see you in the next episode.